and Mr. Mike Silica, and for Oriole Global Industries. A modern, interoperative electronic healthcare record system that fully integrates VA, Defense Department, and community providers is a fundamental part of fulfilling our promise to provide world-class health care to our country's veterans. For more than 20 years, the VA has attempted to modernize their system. About 5 years ago, I was hopeful that the VA was on the right track when it decided to acquire the same system as the Defense Department and then signed a contract with Cerna. However, we are now in a reset period. I recognize the need for the reset and appreciate that the VA Oracle team is working to fix the issues with the system itself and VA's implementation plans. Together, VA and Oracle must resolve the technical issues within the system. VA senior leadership must standardize VA processes and systems and eliminate unnecessary specialization. They must decide soon on what works best for most users. The clock is ticking. Frankly, the American taxpayer, they have spent too many billions of dollars for this to fail. And I still want to know where those billions of dollars went. If VA cannot make the decision necessary, this committee will. I would like to recognize Ms. Wasserman Schultz for her opening remarks.
Thank you, Mr. Chairman. Good morning, everyone. Mr. Cecilia, I assume that we share the same problem with just answering to every version of our names. So we welcome you and the other witnesses, and I feel your pain. I want to thank you all for being here, and I want to concur with the chairman, he and I, and our entire committee of varying iterations, because we've had we have some new members who've not really been through the EHRM process with us, and members who have been through the long haul. But the Electronic Health Record Modernization Program, this version of it officially started in 2018. It's supposed to be a 10-year, $10 billion contract with what is now Oracle Cerner, plus an additional $6 billion for program management and infrastructure, which would ideally be a total cost of $16 billion. We're now finishing up the 5th year of the program, despite having appropriated over $10 billion in total, including more than $5 billion for the contract, and we only have 5 sites to show for it. We're more than halfway through the funding contract with Oracle Cerner and halfway through the original expected timeline, and have barely made a dent in the rollout of the system nationwide. Per the original deployment schedule that VA built its cost estimates around, the new electronic health record system should have been deployed at close to 70 sites by now. Now, I want to be clear, I don't believe in pushing out a system before it's ready, and this has certainly been a problem across both parties' administrations. I think it's prudent for VA and Oracle Cerner to hit pause and fix the issues at the 5 sites where the new EHR system is already deployed, and get that right before launching more sites. And clearly, because some of the issues that have arisen, particularly related to the unknown queue, were potentially life-threatening to VA patients, we have to get this right. When the reset is over, the expectation and necessity is a fully functional system that can deploy to the remainder of the 166 sites. The expectation and necessity is no patient safety issues, no unplanned system outages or degradations, and successful end-user adoption of the system. We need a health record system that works and that clinicians are excited to use. It should be easy to navigate and save them time so they can prioritize patient care. I hope we can see efficiencies in the deployments so we can make up for lost time and deliver the new system that seamlessly transitions the single electronic health record from DoD to VA and is interoperable with the community, promises we've been making to veterans for decades. DoD has been relatively successful. They've deployed to all domestic sites and are planning to deploy overseas next month. While DoD does have hiccups, they seem to have finally hit their stride. DoD has done it, and I know I'm going to be the eternal optimist that VA will do it too. I hope to spend this hearing getting a better understanding of where we are in the reset, what issues have been fixed, and which ones remain. I'd like to get a better understanding of where we are financially. VA is adding interfaces, workflows, and capabilities outside the original scope of the project, and that's going to cost more money. As the saying goes, if you see one VA, you've seen one VA. Every medical center is different. One of the reasons why so many people like the current outdated VISTA system is because it has been so customizable to the individual needs of each facility. If we wanted 130 separate systems, we would keep VISTA. But that's not the goal of one seamless electronic health record, and it is important that we do not go down a path of too much customization to VA's system. If you've seen one VA, you've seen one VA is not going to be the mantra for EHR. And we need to culturally embed that in our VA's employees because they are still resistant, and their resistance is strengthened when we go through these really ridiculous bureaucratic and technological challenges. So I want to get a better understanding today how you are reining in the number of workflows, capabilities, and interfaces. And as I've mentioned, the point of EHRM is to have one system that is completely seamless between DoD and VA. VA is not DoD, and there is definitely a need to make changes to support the different population that VA supports and the wide variety of services VA provides, but it has to be balanced. If we customize too much on the VA side, not only is it going to be more technologically challenging to develop, but it's also going to cost more. It'll defeat the purpose of the system. We want a repeatable model that can be deployed at every VA site without special customization at every location, which will slow down the deployment. So I know we're not going to solve every problem with VA's electronic health record system today, but I do hope we can have a candid conversation about where things currently stand and how we're going to make this system successful and improve the lives of our veterans and those who provide their critical care. Thank you, Mr. Chairman. I yield back.
And I agree with everything my colleague said. Thank you for taking the time to be here. Without objection, your written statement will be entered into the record. Please summarize your remarks in about 5 minutes each. Opening remarks will begin with Dr. Evans.
Thank you. Good afternoon, good morning, I'm sorry, Chairman Carter and Ranking Member Wasserman Schultz, and distinguished members of the subcommittee. Thank you for the opportunity to testify today in support of VA's initiative to modernize its electronic health record systems. Joining me today from VA, representing the Veterans Health Administration, is Dr. Jonathan Nebeker, to my right, the Executive Director of Clinical Informatics. As you're aware, VA needs to modernize its electronic health record system. This was just reflected in both of your statements. And the department remains steadfast in its commitment to doing so. The replacement of VA's EHR is one of the most complex health IT projects ever undertaken within one of the federal government's largest organizations. This project will impact more than 300,000 VA employees and more than 100,000 trainees who will eventually use the new system yearly, and more than 7 million veterans whose care will be orchestrated and documented within the system each year. But I should emphasize that this is much more than just a change in technology. The EHR change by its very nature requires VA to revisit, reconsider, and where possible to standardize clinical processes and workflows. There is a direct impact on the very operations of the health system because electronic health record systems profoundly impact how care is delivered in the modern healthcare system, how clinical staff can access and organize the information that they need to care for veterans when and where they need that, how instructions for care, also known as orders, are transmitted and received within the hospital, how appointments are scheduled, how complex and high-risk care is organized in our ICUs, how surgeries are successfully planned and completed, how prescriptions are entered and provided to patients, and much more. Getting this right requires a massive team effort across the entire VA enterprise, attention to detail, effective communication, and consistent execution. Despite the challenges we have experienced so far, VA must continue to move forward. In fact, The suite of technologies that make up a modern electronic health record are just part of a larger ecosystem of orchestrated technologies needed by VA to enhance the quality and safety of healthcare delivery, to empower clinical teams with the decision support that they need, and to advance veterans' engagement in their own healthcare. It's this entire suite of technologies, both the federal EHR and other critical health information technologies, that need to be modernized and integrated effectively to simplify the healthcare experience for veterans and VA staff, to enhance standardization across the VA enterprise, as was mentioned earlier, and to improve the VA and Department of Defense's interoperability with the rest of the U.S. healthcare system. As has been mentioned, VA is implementing the same electronic health record as the Department of Defense, the U.S. Coast Guard, and the National Oceanic and Atmospheric Administration. And this system is often referred to as the federal EHR. DoD has completed their deployment of the federal EHR, which in DoD they call MHS Genesis, at all of their clinical sites in the continental United States, with the exception of the joint VA-DoD facility in North Chicago, Illinois. And DoD will finish their deployments outside the continental United States this fall, and then together we will implement the record at the Lovell Federal Healthcare Center in North Chicago in the spring of 2024. In the VA, the federal EHR is currently in use at 5 VA medical centers, 22 community-based outpatient centers, and 52 remote VA sites like telehealth hubs and call centers that serve the locations where the record is live. There are more than 10,000 VA users of the system and more than 200,000 veterans who live in the areas that are served by this new EHR. We've been listening to veterans and clinicians, and it became clear that the federal EHR was not fully meeting expectations in VA. And therefore, in April of this year, VA announced a program reset, halting work on future deployments of the EHR except for the Lovell Federal Healthcare Center. As a result, we're now focusing on delivering the improvements needed for current system users while also preparing the enterprise for future deployment success. Staff productivity, revenue collections, technical system performance, user adoption and satisfaction, and other areas require dedicated attention and positive improvements before deployments resume at full pace. VA has organized the work of this program reset into 3-month increments and just completed its first increment on August 31st. Initial efforts focused on making necessary system changes, improving the technical stability of the system, enhancing end-user support and ticket management, addressing communications within VA, and developing a larger cohort of VA experts who can support the new system in the years to come. We are making progress, and yet there's still more work to be done before we'll be ready to publish a new schedule and proceed with deployments across the rest of the VA healthcare system. Chairman Carter, Ranking Member Wasserman Schultz, and members of the subcommittee, thank you again for this opportunity to testify.
Cecilia. Chairman Carter, Ranking Member Wasserman Schultz, and members of the subcommittee, thank you for inviting me today. And thank you for your past and current support of the VA's EHR modernization program. Since Oracle's acquisition of Cerner in June 2022, we have seen the critical importance of not only your support, but also your active engagement and concern for the program's success. We share your concern, and since day one, we have made turning this program around our top priority. Oracle is proud to be working with VA to modernize its EHR system, and we believe strongly in the importance of this mission. The EHRM program is the largest health IT modernization project in history, replacing the decades-old Vista system. This modernization involves not only updating the EHR technology to ensure our veterans receive the best, most innovative, seamless care possible, but also change management and governance challenges in moving from 130 systems to one. The initial deployment of the system to 5 VA medical centers has been challenging on the technology side and the user side, and further deployments are paused while the program undergoes a reset. We are supportive of the reset and believe that it, along with the renegotiated contract, provide the foundation needed for the program's ultimate success. In the new contract, we agreed to 22 service level agreements, or SLAs, to measure Oracle's performance. If we fail to meet these SLAs, we are subject to harsh financial penalties. We currently are meeting all 22 of them and intend to continue to do so. One issue that has received a lot of attention in the past is system outages. But since implementing our engineering changes, The Oracle-owned outage-free time has been 100% in 11 of the last 12 months. Oracle has long been in the business of providing stable and secure enterprise-class systems to governments worldwide. We are confident the system will be able to perform for current users and scale at deployments for future users. Much of our confidence is gained from the system's success at DoD. The initial DoD rollout was similarly challenged for the first 2 years, only completing 4 deployments and then taking a 2-year pause to improve governance and fine-tune a standard enterprise baseline system. Those efforts enabled DoD to achieve a repeatable deployment model. From there, DoD completely deployed the new EHR domestically in less than 4 years, with overseas deployments scheduled to start this October. This includes deployment at DoD's most complex facilities, such as Walter Reed Medical Center, with no instances of patient harm and a quick rebound to pre-deployment clinical productivity. During the reset period, we're working together with VA to make 270 workflow reconfigurations, which will result in more intuitive system interactions for VA providers. Additionally, we recently extended the reach of our Joint Health Information Exchange to 90% of all community hospitals serving the VA and delivered a package of upgrades with pharmacy and patient safety enhancements and other reliability improvements. We further believe that the work being done now planned for the deployment at the joint VA-DoD facility in Chicago in March 2024 will demonstrate that the system is scaled to function well and handle operations at complex facilities. As we continue to proceed with all of this work in the reset period, Oracle stands ready for VA to put their success criteria into a plan and provide a schedule for resuming deployments. With regards to cost, a year ago, I committed in testimony to the Senate Appropriations Committee to keep cost in line with the contract ceiling, barring major new requirements from the VA. This commitment also includes moving the EHR to a modern cloud-based system at no additional cost. Once we begin deploying again, we should be able to speed deployments. As I've said, to do so will require achieving a repeatable model during the reset. Not only will this minimize costs and allow more predictable, timely deployments, but it will also allow VA to achieve a consistent provider and veteran experience and quality of care across its system. There is much to do, and we appreciate that this reset period gives us time working with VA to get this right. We look forward to delivering an EHR system that succeeds at VA and provides our nation's veterans with the type of modern healthcare system they deserve. Thank you again.
Well, thank you. We both have, quite a few have some questions. I have 3 questions. I'll expand on them. How much is needed for FY '24? How much money? Why are we at this point? And what are we doing to fix it? That's the 3 questions. The President requested $1.863 billion for FY '24. VA has modified this request. We know there's going to be significant amount carried over from FY '23. Assuming we continue this initiative, how much additional funds will be required? I don't want to play the blame game, but it's important to understand why we need this reset after we've had other strategic pauses and reviews. What should have been done differently from the beginning? Why aren't the technical issues and training adoption challenges identified and addressed 5 years ago? As I said in my opening statement, we spent too much money already. We want to make sure this doesn't fail. And one of the things, you gave a list of things that that VA had to do. Now my question, somebody gave me a timeline over here, pretty interesting. '83 we talked about it. '86 we started talking about it and talking with the defense. 2000 began the first modernization project. 2009, and there was other money spent in between, because I came on in 2004. 2009, we entered into a critical issue with the accounting department. 2011, more issues. 13, 15, 17, 18, 20, 21, 22, 23, now 24 to 28. All that time, VA had to make those same people come online with us. Why haven't the conversations gone on? And then those other questions I ask.
Okay. So I'll start with the timeline that you laid out. I guess I'll start with saying that I started my career in VA in 2001. I finished my residency, and my first and only job has been with the Department of Veterans Affairs, a place that I'm incredibly proud to work, serving veterans every day. I started seeing patients just 3 miles north of here at the Washington, D.C. VA Medical Center in 2001, and I'm still taking care of the same panel of patients that I started taking care of in 2001. I'm in clinic twice a week, caring for patients. In fact, I have virtual care telehealth appointments this afternoon after we finish here. And I will say that we have made an investment in health information technologies, and the situation when I see patients now in the clinic versus 2001 is entirely different. And so I think the investments that we have made over the course of the last 20 years have led to value. I don't remember the last time I could not find a piece of information that I needed from the Department of Defense healthcare system in real time in a clinic visit with a patient. I also am increasingly getting access through the effort of this modernization effort through our joint health information exchange, which you heard Mr. Cecilia mention, that private sector data, community health data, data from outside hospitals when I'm seeing patients, I'm also often seeing that directly in our electronic health record systems because of the investments that we've made, instead of having to run back and forth to the fax machine. We're delivering more care by telehealth and virtual care. There's a long list of areas where we've made significant improvements as a result of the investment to date. Having said that, we need to get right the path forward to modernize the electronic health record. And one of the value propositions here is moving from a federated system of 130 different instances of an electronic health record to a single integrated national health record. And that does require the hard work, as has been mentioned, of figuring out how we standardize how care is delivered. That one VA is not, that once you've seen one VA, that's saying that you've seen one VA, you've seen one VA. No, we should be able to deliver care in a consistent way across the enterprise. Those conversations have been happening, more need to happen, but I guess I would say my answer to your question around the timeline is we are seeing value. With regard to this particular effort of the electronic health record modernization, we need to push harder to get to the finish line, as we've clearly established. With regard to the question of how much funding, you are correct, the original ask was for $1.86 billion for FY24, and we've lowered that based on the reset, based on the fact that at the moment we've paused pre-deployment and deployment activities. There are still ongoing costs to sustain the solution, to do the work of the reset, and we are still committed to deploying, and there is a long lead time from a funding perspective for deployment. So when we get to the point where we're ready to restart deployments at pace, our budget request takes that into account.
Anybody else want to comment?
If I may, Mr. Chairman, I would echo Dr. Evans' comments that we have seen benefit from the Joint Health Information Exchange, which does bring data together, even from existing systems like Vista. I would also say that the spirit of cooperation between the VA and Oracle, particularly in the last year, has been extraordinary. I've been complimentary of Dr. Evans and Dr. Elnahall's leadership as they have joined the EHR program in the last year. And I think we're seeing a spirit of velocity and teamwork that we haven't seen in previous years. So in my opinion, and please keep in mind, I've been involved since June of 2022, so my history is not as deep and as long. But even in that short time, I would say that the working relationship, the exchange of information, the exchange of ideas, and the common goal of driving towards an enterprise baseline, which I do believe will steer this program in the right direction, will allow us to redeploy deployments in parallel, meaning we can do more than one site at a time, and will keep us, at least from the Oracle Cerner side, in the context and in the envelope of the amount of money that was originally contemplated for the entirety of the contract. I don't believe that's an unachievable goal.
Thank you. Ms. Wasserman-Schultz.
Thank you, Mr. Chairman. I guess my first round of questions is we'll focus on the reset and be more granular in the information I'm seeking. The program began, or this iteration of the program began in 2018. It's been riddled with delays, issues impeding its success. We've had a strategic review, the assess and address delay, now what we're calling the reset period, on top of the individual site delays also. There's a few things that I'd like some feedback from you on. One, Dr. Evans, can you describe what the intentions of the VA reset are? What is the very specific short, medium, and long-term goal? And what exactly are you intending to accomplish? Do you have metrics established so you know whether or not you're meeting your goals? How long is the reset intended to last? We'll start there. And I'd like to hear from all three of you.
Okay. So what is the intention of the reset? As I mentioned in my opening statement, we're committed to deploying this record. There's work that we need to get done to be confident that we can move forward with the deployments at pace. We've set 3 goals for the reset. Those are to address the issues at the live sites. We had heard, we've deployed the system and learned a lot from deploying it to 5 medical centers, 22 clinics, 52 remote sites. We're addressing those issues in order to improve productivity of providers, user satisfaction and adoption, technical reliability of the system. We can go through what some of those issues are, but we're addressing the issues at the live sites, number 1. Number 2, we're doing some of the foundational work that is going to be necessary for us at the enterprise to be able to operate this as an enterprise system.
Okay, do you have metrics that will measure whether you're meeting those goals? Because frankly, you're speaking in very broad, rosy,
Yes.
summarizing terms.
Right. So we are organizing our metrics of how we measure our success in 4 categories. First category, the veteran and the staff experience. Looking at we measure on a yearly basis, and we'll be doing it more often than yearly, the satisfaction of our end users with the system.
Okay, but we can't be in the reset for years.
Correct.
I mean, I'm talking about discernible metrics that are going to determine whether you're meeting goals or not meeting goals so that we can get out of reset and go forward with implementation.
I completely agree.
I'm talking about those kinds of metrics in the reset specifically.
Right. So I'll go through the categories, and then let's dive into some specific metrics that I think would be helpful as examples. So use veteran and staff experience, number 1 category. Second is the facility impact on facility operations. Are we returning to our goal levels of provider productivity? As an example of that. Revenue collections. The impact of how this impacts operations and metrics that we have aligned to that. Third, our metrics around the program processes, our change management, our governance. Some of those are yes, no. Did we establish the governance structure, and is it working in a way that we need it to work? Some of them are basically evidence where it's a metric where we can track progress over time. And the fourth area is around the technical performance of the system. That's really foundational. It's got to be up all the time and reliable. Those are very easy to measure. Uptime, incident-free time. Is the system performing? Are users having hangs, crashes, or lags that are unacceptable? I think it's also important, and we're building out the actual criteria, which we will be happy to share with the committee, with the metrics themselves. That is work that we're doing this month that we will be tracking as we move forward. It's important that we do not need to get to perfection on those metrics to exit reset. We need to see a positive trend, improvement in productivity, improvement in user adoption and satisfaction, improvement in the right direction with regard to the technical reliability, which, by the way, we're already starting to see. And so we're looking for the positive trend as the point where we make the decision that we can exit reset.
Okay, so with that said, how long is the reset intended to last? What's your expectation of when you would be able to come out? And what are the indicators that would tell you you could come out of the reset and that we would be in full implementation? And we're holding Oracle Cerner to a 99.95% accuracy rate here. So, and they're, making progress on that. But when are we coming out of the reset? What's the goal? And when are you going to know that that's possible?
Yeah, I think the path to restarting is several-fold, right? Sustained positive trajectory on the success criteria, the metrics that I was just talking about, number one. Number two, a successful launch of the record at the James A. Lovell Federal Health Care Center in the spring of 2024. And by the way, we'll go live in the spring, and with these EHR rollouts, it's usually a month or two that we actually see things settle in after we go live with the new system, and we're able to see the impact of that go live. So if we go live in March, I think we're going to have a lot of information with regard to our progress on the metrics that we'll be setting and the success at James A. Lovell Federal Health Care Center, that in the summer of 2024, we should be having, and even before that, we should be having real discussions about whether we're ready to move forward with restart.
Okay, and Mr. Chairman, with your indulgence, if I can just get some feedback from Mr. Cecilia on your understanding, is that okay? On your understanding of the reset, what engagement you've had with VA to determine the appropriate amount of time the reset would need to last to accomplish VA's goals, and what are your responsibilities in that time period
Well,
between now and next summer?
Our primary responsibility in that time period, as Dr. Evans said, is to ensure that the system is available, is not in the way of providers, and is reliable. And I believe we made demonstrable progress in that. We're also, we share the co-responsibility for the 270 configuration workflow changes that I mentioned in my opening statement, which I think are also a very positive thing. It may seem like a big number, but for a program this size, it's actually not that big of a number. And those 270 things that we are responsible for implementing during the reset will move the program towards standardization, not towards customization. So these are things that we're cleaning up, if you will, and based on direct provider feedback from VA providers who have given feedback around the way the system functions. Again, it's not that we're customizing the system, it's that we're delivering easier to use interfaces for the providers to consume. So there are primary roles in the VA reset. I would concur with Dr. Evans' timeframe, that it seems to me that next summer we should be in a position, particularly with the go live, which I think is trending well in March, that we should be in a position to resume go lives. That is our expectation.
And who decides at the end of the day when the system is ready to deploy again?
The secretary.
Well, obviously. I mean, is there a collective decision that's going to be made, or
I mean, I
make a
think
recommendation to the
I
secretary?
think, in part, one of the things, you asked a question about somebody asked a question about what's different. One of the things that I think is important is there is very close alignment and excellent teamwork between the Veterans Health Administration, the program that is executing the implementation, as well as our vendor partners. We're meeting on a regular basis. We're having these discussions. Our commitment is continuous value delivery during the reset. So I think we're going to be having the continual discussions. I wake up every day wondering, how are we moving in this direction? We don't want to stay in reset forever. In fact, I would argue that we're at higher risk the longer we maintain a healthcare system that's running two different electronic health record systems. And so we need to feel an urgency to move forward with get back to a single electronic health record system that supports the enterprise. I feel that urgency. I know that VHA leadership feels that urgency. I know the vendor feels that urgency. We will be together making that decision. It ultimately will be presented to the Secretary.
Thank you, Mr. Chairman. For your indulgence, I yield back.
Mr. Rutherford.
Thank you, Mr. Chairman. Mr. Cecilia, in your testimony, you talked about being able to speed deployments on a repeatable model and how you successfully did that with DoD. My question is, in light of the conversation that we just had, and notwithstanding the great relationship that y'all have, I want to ask, you can't create, I assume, you can't create a repeatable model unless VA has provided you with the work processes that they need you to repeat. So is there a breakdown? Is the problem here in not having already achieved a repeatable model within VA like you did in DoD? Is it because VA is not providing you with the processes?
I think that historically has been a challenge prior to Oracle's acquisition of Cerner, which happened just over a year ago. As I mentioned, though, I think that the leadership now is staunchly aligned, and I do feel like we are on a path to get that repeatable model and configuration from VA so that we can implement it in a timely manner. And then, as you point out, we can move into a parallel deployment strategy, which I think ultimately will keep the program in line with the original amount of contract that was contracted for the Cerner piece of this. And we can, to make it quite simple, deploy more than one site at a time. We don't have to be in a serial mode where you've got one site at a time. So you're right. We do need the configuration to be able to implement it. However, I am very confident, and I would tell you if I was not, that we are moving in that direction and that the cooperation and teamwork, as Dr. Evans mentioned, is in fact squarely aligned along exactly that point, which is we need a baseline model that we can deploy at every VA site. And then if there are things to tweak on an individual site basis, over time and afterwards, certainly those things can be done. But I think Dr. Evans said it best. We don't need to be perfect to get real value from the system. And I think in the past, it was probably fairly an issue on both sides. And to be quite fair to VA, prior to Oracle's involvement, there were a lot of system issues that I think were technical system issues, technical issues that were frankly a distraction and didn't allow the right attention to these kind of enterprise standards. I mean, if the plane's fairly turbulent, when you're flying, it's hard to serve hot coffee and things like that, right? And I'm much happier to now be into the thing where we're looking at configurations, which is how do you like your coffee, rather than put your lap belt on pretty tight. And that was the situation we were in prior to getting involved. So all that said, I think you're exactly right. I mean, we need to know what to build. I do think that Dr. Evans and Dr. Elnahal are pushing very hard inside VA, and we are making progress. And those 270 things that we are actively working on right now and making, I think, great progress on are in that vein.
So let me go to Dr. Nebaker. Look, when Vista was developing, it was like 130 different. It was all called Vista, but it was really 130 different systems. And I understand you all have to try to overcome that. But my question is, and it's something interesting that Mr. Cecilia said about, the tweaks for individual sites. Are we really going to wind up with 130 different sites like Vista? Is that where we have to go? Because Vista obviously had to go there, and it did. And you all, well, not you all, but VA developed that. And so What's your beliefs, Doctor, about how we can get that, as Mr. Cecilia calls it, that repeatable model at 130 different sites? Is that possible?
So yes, and these are fantastic questions. So the mission of my office, Clinical Informatics, is to advance the standard care, a single enterprise standard of care and experience for the entire VA, using, through standardization of tools and processes. And this is including Vista and Oracle sites. So how do we do this? So VA, under Dr. Elnahall's leadership, and also his deputies and assistant undersecretaries, have all now fully endorsed standardization of care. We know from experience through the difficulties that is introduced in this program that we must standardize care. Moreover, we want the veteran to get the same standard of care whether they're going to Spokane or Salt Lake City or Baltimore. We don't want geography to drive the veteran's experience and standard of care. So how do we do this? So we do this by through a couple of things. So one is we look at processes independent of the technology. How do we want to get our work done? How do we check in patients? How do we communicate with patients? How are we using additional information systems, as Dr. Evans alluded to? How are we doing telehealth? How are we communicating with the patient through their portal? So it's an ecosystem of technologies and processes that we explicitly now are documenting, like in a flow chart. When you check in a patient, this is what happens. When you care for cancer patients, we have clinical pathways. Right. And then based on those clinical pathways, we are standardizing both in the Oracle system and then retroactively standardizing in Vista systems. And then based on the best, really great practices in the Vista systems, forward doing the configurations, not customizations, in the Oracle system, again, to maintain that consistent standard of care so that, and while we're doing that, advancing that standard of care.
But have we done that? Because Doctor, Mr. Cecilia just said that
We have not.
Okay.
But we're making progress towards that end, and real progress, and we have a ways to go. We will not wait. The reset period exit is not going to be dependent upon this, complete end-to-end standardization of healthcare. But we will be making a lot of progress. We already have made progress this year.
Okay, I see my time's way over. Thank you, Mr. Chairman.
Mr. Chairman, thank you so much, Ranking Member. Can you tell me what Kaiser Permanente, one of the largest integrated healthcare systems in the U.S., the Mayo Clinic, a renowned medical practice research institution, Cleveland Clinic, a leading academic medical center, Intermountain Healthcare in Utah, based in Utah, Southern Health network of hospital healthcare providers in Northern California, the Department of Defense, the U.S. Coast Guard, and the NOAA all have in common?
They all deliver health care.
Okay, can you tell me, besides that, what else? I'll give you a hint, the topic today.
Well, essentially, effectively at this point in time, all health systems in America are using an electronic health record.
Okay. Except for the VA?
VA is using an electronic health record as well.
The modernization, integrated.
Right. So I would say that I think if we're looking for what's in common with those healthcare systems, they are all using commercial electronic health records across their enterprise. Not necessarily the same commercial health records. Some of them are actually running multiple different vendors' commercial EHRs to support their enterprises. But they're all running an electronic health record, as is the VA.
So what's the difference between a successful rollout of a modernization, electronic records initiative, and a lackluster situation that we're seeing in the VA. And I say that with all due respect.
Yeah, I mean, I think, look, well, I'll start with saying that electronic health records.
Well, let me interrupt you. Let's look at some of the challenges: scale and complexity, interoperability, resource constraint, data migration and integration, change management and user adoption, data security, privacy, technical challenges, which vendors play an important role, regulatory policy compliance, stakeholders engagement. Which of those challenges are affecting the work that you're trying to do? All of the above? One more than the other one?
Yeah, I mean, I think there's several pieces, right? So first of all, an electronic health record transformation is an IT project, and there are, to your point, technical factors that need to be taken into account. The system has to work and be reliable. We're making progress there. We're not where we need to be, but I think we're making good progress. And that had been a barrier. There is the biggest challenge is managing the change. For providers who have been, and staff have been coming to work using Vista every day for years, they can almost do that in their sleep. They know how to navigate the system, right? And so the system has gotten out of the way because they've learned how to use it so well. Moving to a different system is a change, a significant change. And that change management, I think, has been one of the larger challenges as we've asked folks to move to a new way of doing things. And you've heard much discussion about the importance of standardization. That is, when you're deploying an enterprise system, as opposed to 130 instances of a system that can be customized locally, an enterprise system requires standardization at the base.
I gave you a list. I'm sure somebody took notes of the different challenges. Can you all follow up with committee and tell us where exactly the problem might be? I mean, it's not just simply an IT issue, right? It's more than that. I mean, there's different challenges. When you look at the modernization effort and what challenges have you encounter, it's more than just a IT issue.
Absolutely, and we'd be happy to comment on that list.
Sir?
Yeah, so I think, so what kind of struck me as you're going through that list, and I've had friends, at those institutions leading the implementation, some of which were fired after, because of the main problem with these implementations. And that main problem is change management. So for example, Intermountain Healthcare, I live in Salt Lake City. I'm enjoying the agriculture room here because I'm kind of a farm boy in Callahan from my youth. But it's especially systems like, Kaiser early on that had sort of its own EHR. Intermountain had its own EHR. Mayo Clinic had its own EHR. The hardest problem for them was to get out of their heads about how do we replicate our EHR, our custom EHR that was tuned over years and decades in some cases to make my workflow a particular way. And so what they've done, and failed doing it, is trying to make the commercial EHR system like their usual custom, highly tuned EHR system. They've overcomplicated the solutions. They've tried to break standardization with all good intentions. And almost all of these healthcare systems that you've listed have had to enter a reset period. They've called it different things, but they've had to step back and say, wait, what are we doing here? How do we get back on track for a standardized approach that fits the commercial solution that we have, not trying to make the commercial technology like our custom technology? That's the commonality that I see.
And my time's up, but let me just say this. But are they in a better situation? I just listed a whole bunch of private, non-for-profit, and government agencies. Even though they went through a reset and they had the same, they're I would say, in a better situation than the VA.
Yeah,
So
in many
let's
cases-
look at the lessons learned. That maybe some folks have been fired for coming up, but some folks probably got promoted for doing the right thing also. So thank you so much. Appreciate it. Thank you, Mr. Chairman.
Thank you, Mr. Chairman, and thank you both for being here, all three of you for being here this morning. First, I want to say I was a little surprised to hear that we are pushing the reset into next year. I certainly think that I understand that there are some challenges that we need to address, and we want to make sure we rectify those before we push forward. But a year delay seems like a very long time, given that we've already spent 5 years into this project. I want to follow up on the ranking member's comments. Dr. Evans, with all due respect, I think the 5 minutes that you had at the beginning was a really vague, high-level overview. There wasn't a lot of nuts and bolts as to where we are and where we're going. So I think that I would like to see, and I think my colleagues would agree, a very detailed outline of what the metrics are, what your expectations are, and what the timeline that you believe you'll be able to meet to be able to restart this program for next year. On that note, it was mentioned, Mr. Cecilia, that you've renegotiated the contract. Can you talk a little bit about why there was a renegotiation and what the specifics, details of that were?
Yeah, the primary point of renegotiation was to move to a more granular level of measurable system-level agreements. So in the original contract, there were either 4 or 5, which frankly is usually a usual pretty low number for a contract of this size. This was a Cerner contract, not an Oracle contract that was signed. So we moved to 22 system-level agreements, and this was in collaboration with the VA. The reason was we wanted to be very transparent very public about everything that we're measuring, and all of those SLA compliance reports are available on a congressional dashboard for everybody to see. And I think that's it holds us all more accountable to have a contract which is far more granular, at least along the technical system things that are fairly easy to mention. The other piece of the major piece of the renegotiation was to move to a series of 5 one-year options rather than a 5-year extension. You know, given the uncertainty around reset periods and given the uncertainty around what may be the end result of that, I think the VA felt it better to move to a series of one-year extensions, and we supported both of those decisions. That said, we have no intention to do anything else but continue to support this for the original amounts contemplated and for the timeline contemplated, and to continue to move forward.
There was no additional cost renegotiated in the contract, is that correct?
No additional cost renegotiated.
Okay, I'm glad to hear that you're committed to the project, because it does worry me a bit that we've renegotiated to a 1-year extension every year rather than a 5-year. I think that leads to concerns about canceling the contract and going a different direction at some point, which is a huge problem for all of us, I think, on this committee. If I can pivot for just a moment, I want to ask, it is an incredible honor for me to represent Congressional District 5. I have about almost 50,000 veterans that reside in my community. And the Oklahoma City VA Medical Center has already completed construction to allow for additional service space in the forthcoming transition. Do you have an idea where this particular project will fall in the timeline? And have you given out a sort of projected summary of when you'll be doing each VA facility?
One of the key tasks that we are working on in the reset, and that we've actually just started right now, is to re-look at what our original deployment schedule was. And you heard mentioned here at the table already that there's an opportunity to rethink what that looks like. The DoD, as an example, moved from a model where they were doing a series of individual deployments to doing what they called waves, where they were deploying multiple medical centers at the same time. They were able to move more into parallel. They started to think about where markets where we should go live as opposed to individual medical centers in order to make the transition where there's resource sharing. VA operates and shares resources between medical centers. So in short, we are going back to the drawing board with regard to what the schedule should look like, taking into account the investments we already made. So for example, in Oklahoma City, we have made the investments in the preparation for the technology. So where we've made investments, that will certainly be a factor in how we consider what that new schedule should look like. But we've committed at the end of the reset, we will publish a schedule. And
Are you also giving the regional centers advance notice on what they may need to do to be able to meet the expectations to go in and start the process?
Yes, and the intent is, and we will be having the conversations with the regional, the VISNs, the networks, to say what is right for you, right? This needs to be driven by them.
I'm running out of time, but one final question. You mentioned the 130 different variations of the current platform that you're having to navigate. Are there any specific sites that you have concerns with based on how the program that they currently use is structured that could be very much more complicated than other particular locations?
I don't personally have any particular concerns about any given site, and as Dr. Neviker mentioned, one of the other things that his team is doing is looking at how we can start to standardize better in Vista in preparation for the change. If we start to do the change at Vista sites before we even arrive with the Oracle record, that transition will be easier.
Perfect. Thank you for your indulgence, and I would, once this is concluded, love to have those additional details that we talked about as far as metrics that we want to try to adhere to. So thank you, Mr. Chairman. I yield back.
Bishop?
Thank you very much, Mr. Chairman, and let me thank you all for being here today. I believe I've been serving on this subcommittee longer than anyone on the podium, and quite frankly, I am frustrated that our veterans have been waiting more than a decade to try to get this situation accomplished. Year after year, first it was struggles between the VA and DOD. We appropriated millions and millions of dollars. We finally get to a point where we think that it's going to get done in 2018 after all those years. And we continue to have problem after problem after problem. What is it going to take? And what will the costs be safety-wise to veterans while the data is being transferred? What steps are you taking? I think the GAO has indicated that there were some issues with allergy and medication and immunization data which affected patient safety concerns. During this process, which now has been almost a decade and a half, I mean, veterans are having to suffer. And how are you maintaining the risk level to make sure that veterans are not impacted by this transfer process? And what lessons have you learned with the deployments that you've already done that are going to inform you to try to get this done? And ultimately, with all of the billions of dollars that we have already spent, and every year we're adding more to that, ultimately, what will be the cost savings? Will we ever recoup our investments? And how are you going to, do you have metrics? And I've heard a lot of questions this morning about the metrics. What are your ultimate metrics for rolling out this system? Can you just kind of address that? My frustrations are really welling up because I've listened year after year, meeting after meeting. I've heard people from VA, from people from DOD talk about where we are on this, and I've seen the appropriations bills roll out, billions of dollars. Please, can you address that for me?
Let me start. I've been with the program through the EHR, the DoD program, and also my office used to run the Health Information Exchange, and I'm sure you're one of the people that got calls from your constituents that said, I've had to take a wheelbarrow and collect all my records from the various VAs and wheel those over, from DOD and wheel them over to VA. And literally this has happened, 15 years ago. But since that time, as Dr. Evans, we actually have made a lot of progress, not satisfactorily, I will agree with you, but we have made progress where now within 3 minutes, I can get a veteran's record from anywhere in the country. Again, we're connecting to 90% of hospital systems. Anywhere in the country within 3 minutes, we do a query, we go out and get their episodes of care, hospitalizations, office visits. It's there. It's not integrated. It's like in a PDF, but that's the state of the health information exchange. But let me go back to some of the issues that you talked about specifically, patient safety. So I made a career, one of my past lives was a researcher in patient safety, especially around IT systems. One of the problems we have is we try to make, that causes safety problems, is we try to make the system, another vendor system, work like Vista. And so we've come into these with our human processes that are tuned to work with Vista and trying to apply those same human processes to work with Oracle. That's been a problem. And some of the unknown Q issues that you brought up are related to not understanding how to really work optimally with the system. In addition to changing our workflows to work optimally with the Oracle system, we are doing now a proactive, we're getting the data from Oracle into our enterprise data warehouse and running algorithms on those data to proactively identify problems before they even, before the healthcare systems themselves know that there may be a problem. Again, safety is a Swiss cheese problem where you have to line up all the holes in the cheese for something to happen. And so we can detect electronically when the holes are lining up before there's patient harm. So we're combining many systems, supplementing the Oracle systems to get to patient safety. And I won't take any more time, but I'm happy to elaborate.
Anyone else want to comment on that?
I mean, I would just emphasize, I think I agree wholeheartedly with what Dr. Nebeker just said. First of all, I think we have made a lot of progress. And I think it's we have an application called the Joint Longitudinal Viewer. And when you open that application, which every VA clinician is opening today, or most of them are if they need information, they can see information from every DoD site, every VA site, and 90% of American hospitals. And so we've made a lot of progress with regard to the availability of the data.
How close are you to the finish line?
The finish line is, there's health data interoperability is one question. Do we have access to the data that we need to take care of veterans? And I think we're getting closer access to the data, but the ability to use that data and have it integrated into an integrated, single, standardized national health record, we need to get to the finish line with regard to this project.
Well, how close are you to that finish line? I mean, we've got VA clinics all over the country. We have CBOPs. All of them need on a daily basis to have access to that information.
They have that now.
They're still expressing to my constituents and my caseworkers problems accessing that. And they're also expressing that they're having concerns with getting accurate information. So I'm just frustrated. I mean, this has been almost a 20-year process for me. There are different people that come and sit at this table, every 2-3 years and give us updates. But, we may be not where we started, but we are certainly not where we had hoped to be 10 years ago. Mr. Chairman, I yield back. My time has expired.
Mr. Gonzalez.
Thank you, Chairman Carter, and thank you for holding this hearing. And I echo my colleague, Representative Bishop's frustrations. I feel like we're in the twilight zone. This hearing is not going well for you. And I'm a veteran. I spent 20 years in the military. I'm a retired Navy Master Chief. I believe in results, not excuses. And I hear a whole lot of excuses. And this is dangerous. It is dangerous on two fronts. People are dying, and it's costing taxpayers money, not a little bit of money, a lot of money. So let's talk about the health of people and their welfare and some of the failures that the VA has done that has caused people to lose their lives. So let's start, Dr. Evans. Last year, the VA Inspector General found that the department's electronic health record system had failed to flag patients who had been identified as suicide risks, gave doctors inaccurate information about patients' medications, and caused delays in scheduling appointments. What percentage of these issues have been resolved, and how many of these problems still exist?
Specifically with regard to the suicide risk flags, that problem has now been resolved. Suicide risk flags have been implemented in all of the key components of the federal EHR and are available.
They've been resolved. So the VA is not responsible for not identifying any of these issues. That's what you're telling me.
That report that you're referring to was referencing the fact that suicide risk flags, the electronic health record, the new electronic health record, the federal EHR, is composed of different modules. There's the module that the provider in a clinic would open. There's a module that somebody who's doing scheduling would open. There's a module that somebody who's organizing x-rays and radiologic care would open. And the patient record flag, the flags for suicide risk, were not visible in every one of those key clinical applications. In the past, we just had a single application in CPRS Vista, and that flag would appear and folks would see it, and everybody was using the same application. But based on the architecture of the federal EHR, there are multiple views, and we need to make sure that those suicide risk flags were appearing in all of them. As of this past block upgrade, which was just delivered 2 weeks ago, the last of those applications had the suicide risk flags added.
Do you agree the importance of ensuring that this doesn't happen again, and we make sure that
Yes.
this going forward is a priority? I spent 20 years in the military, 5 years in Iraq and Afghanistan. You know, this week we just celebrated, we just honored 9/11 and the victims. You know, a few months ago or a few weeks ago, the withdrawal, the debacle withdrawal of Afghanistan. I mention these things not as political points. I'm going as veterans of the Iraq and Afghanistan war. This is very personal to us, and it's hurting us. It's causing many people to go down very deep, dark paths, and we need to identify that. They fought for us. I fought for us. A lot of people that have served, we've done our part to keep this country safe for decades, and we have to do our part, both the Department of VA and Congress, in order to fix this problem and make sure veterans are taken care of. So that's the human element part of it. Now let's talk about money. You're coming before the Appropriations Committee. This year, $1.9 billion for this program. Last year, $1.6 billion. The year before that, $2.3 billion. The year before that, $2.6 billion. The year before that, $1.5 billion. That's $10 billion of taxpayer dollars. What the hell has that gotten us? You mentioned something earlier. We need an urgency. I agree with you. There absolutely needs to be an urgency in fixing this issue. What if we cut funding? Would that light a fire? What if next year was zero? Would that light a fire in fixing this program?
So you asked two questions. I'll answer the first question. What are we getting for the investment? The investment, there are three parts to that investment. There is the money that we're spending to implement and deliver the electronic health record solution itself. There is money that we're spending in order to work through the changes that we need within to manage the program. And then there's money that we're spending to upgrade infrastructure, IT infrastructure across the enterprise to support the new EHR, and frankly, it will support other key healthcare delivery outcomes, like being able to deliver telehealth from our remote clinics, et cetera. That IT investment is going to deliver value no matter what, and that has continued. So we have expended on the infrastructure side $2.1 billion. And I think there's real value seen from that. With regard to the electronic health record, I think you've heard clearly from all of us at the panel, we feel an urgency to deliver that. We anticipate that as we finish the reset, find a new strategy to move forward with regard to deployments, we will be able to accelerate the value provided. There's a lot of upfront investment that's required in order to move forward. As to your question of if the budget was zero, I think that would be very hard for us to execute the reset activities that we need to move forward.
My time is up, but I would just say the takeaway needs to be the gravy train's over, and there are cuts coming. And we got to make sure, if you want people to protect some of these programs, there has to be results. You got to look back, and we got to be able to defend where taxpayer dollars are going. And if we can't, then it's just going to put a lot of scrutiny on our things. This is personal. My wife gets her health care through the VA. My friends, everyone I know, I do. We want to fix this. This committee, you've heard this over and over again. We are committed to do this. The chairman wouldn't have brought this up if it wasn't an important issue for all of us. Please work with Congress, find the solutions, let us know what we need, and I yield back, Mr. Chairman.
Thank you, Mr. Chairman. Thank you, gentlemen, for being here. I apologize for not being here on the front end. I missed your testimony. I was hoping to hear more, but candidly, when I read through the written testimony provided in advance, I found it so vague I couldn't really take anything away from it. I mean, if we were playing MBA jargon bingo, we'd have maxed out the card. I mean, there's every buzzword known to man in here, but very light on specifics. So I'm just kind of following up on obviously you can tell there's a sense of frustration among the committee here, but Mr. Evans, you'd mentioned with respect to the reset a couple times, things like we're going back to the drawing board, or as we find a new strategy. Could you be more specific with that? Because there's a growing frustration that we've got an open checkbook and we're spending billions of dollars every year. And I'm curious to know from your perspective, is this a failure from Oracle's perspective to deliver? Is this the VA crawfishing and moving the goalpost at every turn on what it wants, what it's looking for? Is it some combination? But how are we going to get to a point where we can deliver for the veterans out there? Who honestly, and I talked to them in the district, they honestly feel they're all going to be dead before this happens.
Yeah, if I could ask so I think what you're asking is specifically, for example, what are we accomplishing in the reset, or what does it take?
Well, that too, and when we talk about setting a new strategy, who is the person specific for that strategy?
So
who signs off on that and says, yep, this is our new strategy going forward, this is what we've learned from the reset, and here's how we're going to fix the problem? Who's got the final say on that?
Right. Okay. So I think specific to the strategy, right? One of the things that we've talked about is we need to build the expertise inside of VA to own and drive what this looks like for us in the future from a perspective. So Oracle is sitting to my left. We need and are dependent on the vendor, but we need to be able to drive this and understand what good looks like with regard to the EHR. That's an area that we are focusing on. We need to revisit what our deployment strategy looks like. Should we be deploying multiple medical centers at a time? How do we sequence this in order to implement the record?
So the strategy to this point clearly didn't work, and that was trying to roll it out to too many too fast. Is that?
I think we've learned a lot from our first 5 deployments, and I don't think we've arrived yet at a conclusion, but if we were to line up 160 or 159 more medical centers and do them in sequence, this is going to take a long time to get done. And so, Dr. Neverker, you have some thoughts?
So the main strategy shift is treating this as a change management project first and a technology management second. So that kind of goes back to Mr. Kaler's questions as well. What's different? What's the same with all these other healthcare systems? What are we going to do differently? So let me just walk you through this. So the difference is we had a current state review of what's going on at the sites. Well, originally that was a Cerner task where Cerner sent out its people to say, okay, what's going on with the technology? Well, that's just a small piece of the puzzle. Now we're going out and saying, how are you doing your work? And then how does that work need to change? That information that gets rolled out to the people, we're training the system on to say, this is how you have to change your work. Second, we are actually verifying with the VA people that the configuration is working. We're running through workflows, say, okay, not just how do you enter an order, how do you do the technology, how do you accomplish primary care? You're checking in the patient, you're doing the at the front desk, then you're sending them to the nurse, then you're sending them to the physician, then you're doing a checkout review with the pharmacist, and then you're doing a checkout review at the desk. So it's the human process integration that is new, and we're doing much more aggressively. So finally, the training. So the training, and we'll, I'm sure, have an opportunity to talk about training a lot in future questions, is we are looking at the entire journey of the training. It's not just how do you enter an order, how do you do a referral, how do I look up a lab test. It's the training is how do you use the technology, how do you use the technology in your workflow, and then how do you create shortcuts that work for you. There's little key shortcuts you can enter in, like 2 or 3 keys, and get stuff done faster. And then also we're looking at adoption. How we're having at the elbow support as people, more aggressively as people are there, so they have a peer, another physician, another nurse, or another expert who can say, hey, this is how I see you're doing it this way. Maybe if you did it this way, you'd save 5 minutes of your time trying to instead of being frustrated. And then finally, we monitor the system. Oracle has really excellent tools for monitoring the behaviors as people are using the system to identify people who don't quite get it. And so then we can, my team then and the field health informatics staff at the facility can say, hey, we've identified some people. Let us proactively reach out to you to help you use the system better. So these are just a sample of what we're doing differently now to make things work. Some of that we've fully implemented, some of it we've partially implemented.
Thank you, and I yield back.
Well, thank you, Mr. Chairman, and nice to see you again, Doctor. And since I saw you last, you've aged a little bit. Then again, so have I. Some of it, because I agree with my good friend from Georgia, is that it's been a long time and it shouldn't be this long. So clearly, and I understand, the change in primes, and that was a big deal. That's like in a combat way, it's being jumped in the middle of the firefight without, and you got inherited what you got. And I also understand the complexity of the problem, but the frustration I think we all feel is that when can we move from implementation to maintenance? And along the way, we know that we've learned a lot, and I get it, and it's a very complicated system. And the next phase is probably going to be AI. Because you're going to ask, but we from our side is that when do you anticipate milestones, and how are you outlining? Because from a military point of view, I've always appreciated objectives and a plan to get there. So the objectives you've kind of laid out, and I'm sure we'd all like to know the objectives in a little more detail about what are you seeing on objective as far as a program, a system that works. So then you can go to maintenance. And maintenance is always going to be process improvement, and we're going to be integrating things. But at what point in time do we move where we've now deployed the asset, and I understand the training, to now the next phase, right? And that's, I'm sure, what we all, at the end of the day, is just want answers of when we get there. But we got to have objectives, and we got to have a plan to get there. So walk me through what, in a perfect world, where do you see the whole integration system so most of us that are not in the industry can go back to our constituents and say, we think that the program on phase 2 on maintenance, we think we'll wrap up what we're doing here and we'll have a good system that meets the objectives. Can you walk me through real quickly this is a hearing, so I don't expect exact dates, but just a sequence would be nice of how you view it to reach the goal line. And Dr.
Yeah, so I'll start. I mean, Dr. Evans runs a program, but we are working very closely together and trying to plan this out. So what we're doing now is, instead of being activity focused, we're trying to be results focused. So we want results for any project in no shorter time than 3 months. And so let me just kind of walk through some of the activities that we have. So one, Mr. Cecilia kept referring to the 270 issues that we're addressing. So we started, we met in Kansas City with the Oracle team, and that started, what was that, like 3 weeks ago, 4 weeks ago that we did. So now we have very clear milestones, and I would be happy if you'd like them to provide those to you for those 270 items when we expect to finish those and deploy those. And those, again, are changes that the user's experience. It's not just like, let's come up with a plan, let's have a meeting. It's like results that we're delivering to the field.
I'm sure all members would love to see the milestones.
So, great, we'll take that for the record. And then, and so we have a bunch of focus projects that we're working on. We have 6 work streams that Dr. Evans' team is leading that VA, Oracle, and OIT are all participating in. The first is those 270 projects for improving the user experience, the efficiency of the system at the sites. The second is workforce development. This is getting informatics people, so the people will kind of help users use the computers at the sites trained so that they can better help with adoption and use of the system at the sites.
And turnover, you're always going to have workforce development.
Yes,
So
and that's a sustainment
This is
part.
like commission of a ship. Well, when you got everything on board and you're gonna launch it.
Right, and sailors come on, you hire new sailors, they
Hey,
they get restationed, exactly.
Maintenance never ends.
Right, and so, and it's the entire responsibility of the field health informatics workforce to do that, because Oracle and the program, Dr. Evans' program, has moved on to the next wave of sites. So we are establishing now, we're training people up to be able to do that maintenance activity. The third project is help desk incident management. People are complaining, look, I enter a help ticket, you close it, what's happened to it? Where's my ticket, you know? And so we're now having, and we made a lot of progress in this, and also reducing the time it takes to evaluate tickets, clear metrics for that. There's more and more here.
In just a
I see at
time, when
yeah.
do you think the commissioning will be, in an analogy? Because I'm a naval officer.
So again, to Dr. Evans' point, let me say this, it's not going to be an answer that I'm going to give you the date, but we will have, once we go live at a level 1 facility at North Chicago, and several months after that, seeing how the aftermath of that, we will have a lot of information to make that decision. So by spring, summer, we will have the information to make that decision, but we're committed to not go live, to choose it, to prejudge a date, to go live when we're not ready.
And Mr. Ziggy, I think you're asking a question as well about when are we at the end of the implementation, right? That is, when is the ship launched, and now we are
And there's
fully
going to
in
be,
maintenance.
you're going to be sea trials, there's going to be all sorts of things, you're going to be tweaks to it, and someone's going to ask you to do different things, and I get that, but when do you perceive the $10 billion investment, we can say, all right, we got it. Now, the ship's afloat, now we're gonna adjust the course and do all this stuff. Because in most of what I'm hearing from my colleagues on both sides of the aisle, from veterans, is they want to hear this is the date when we're ready to launch, in condition that it is, and get a win on this. 'Cause I think we all want to win, and we want to make sure that our veterans are taken care of, and records are probably one of the earlier steps.
Yeah. Yep. Understood.
I yield back, sir.
Ms. Wasserman-Schultz.
Thank you, Mr. Chairman. I want to focus on training and adoption of the system and the obstacles that are presented when training is faulty or falters. So GAO recently came out with a report in March of this year on change management challenges. User satisfaction included system issues. So, I mean, it is good that VA is seeking feedback, but those results were not very optimistic. Strikingly, based on VA's September 2022 survey of the satisfaction of the system at the time, only 6% of users in March agreed that the system enabled quality care, and only 4% of users agreed that the system made them as efficient as possible. And those are very concerning numbers, but user dissatisfaction is not a new issue, and we know that there is resistance to this change built into the culture of VA. So I'd like to know, how are you working to restore users' trust with the system? Because obviously there was already inertia, there was already resistance, even at the outset of shifting to a non-customized interoperable system. And then, you know, anyone's confidence who worked there and frankly, patience, confidence as well, would be shaken by the number of times that we've had to name a do-over. So what are you doing to work to restore users' trust with the system, achieve user buy-in? The more delays we have, the harder it's going to be, and we've had user adoption that hasn't gone so well so far. And how are you measuring VA end user satisfaction? And are there metrics in place to consistently measure that satisfaction? And that's really for Dr. Evans and Dr. Nebaker. And then, Mr. Cecilia, I have another question for you, too.
Yeah, I'll start with the user trust and user buy-in question, and then on the satisfaction, I think I'll ask Dr. Nebaker to comment on that. Your points are important. It's one of the reasons why one of the significant focus areas of the reset is on addressing the needs of those at the live sites. We have 10,000 users who are using the system, and we need to build back confidence with that user base. They are the ones who will be able to share with their colleagues at other sites about the success of the system. And it's by addressing the issues that they have identified in using the system, that's going to be a keystone, one of the most important parts of how we get to success. Partly we're doing that by identifying what the issues are and what the challenges they're facing, and then working them down. As you heard Dr. Nebaker said, we are working those issues and prioritizing those issues for resolution, for making the configuration changes, or for thinking about how we change the process to support it better matching with the new electronic health record that they're using. I think
How are you measuring your success in that arena?
right, and so talking about user
You're
status.
listing the things you're doing.
Correct.
Great. How do you know that the culture is changing, that the satisfaction is improving, and that the transition from full customization to a seamless interoperable system between VA and DoD has been accepted and the training has been effective?
Yep, go ahead.
So the foundation of user satisfaction is a working system. And Mr. Cecilia has mentioned the great progress we made in reducing outages and hangs. Because that's he used a word that you may have missed, Oracle owned. So within the enclave that Oracle operates, they're doing a terrific job. However, there's many other connections that are causing slowness in the system, some of which we don't fully understand and we're still working to solve. So there's a very big effort where we can measure, we're buying new software to actually measure all the lags and hangs, all the interruptions that providers have. Intermountain Healthcare has implemented these, other healthcare systems have implemented this new software, and we'll be doing the same to get at the granular details, because that's what's killing people the most. The frustration, I just want to get my work done. Why am I having why do I have to wait for 30 seconds for this page to load or something like that? The class measures, KLAS measures, as for the ARCH Collaborative, which is a usability collaborative. About 20% of people in that are Cerner customers. Most of them are Epic customers. They have a series of best practices. The survey that you have mentioned comes from KLAS class. And what healthcare systems do typically is they not do it once a year, but they make an intervention, then they measure. Mm-hmm. And they may measure all the, I think there's about 24 different items on the test. We're only using 11 right now. We intend to use the full measurement system and then repeat the appropriate measures to a sample of the people, not bother everybody at the site, but a sample of the people at the site to try to get in real time the responsiveness of the measures to our interventions.
Okay, and Mr. Cecilia, when the go-lives resume, how are you going to take the lessons learned from previous training issues, the gaps, the go forward too soon, which clearly occurred, and there wasn't enough training and enough buy-in, so you can optimize the best training experience and quality and schedule for end users? I mean, you can have the best system, but if you don't have clinician buy-in, we're still going to have a problem with adoption.
Yeah, well, to your point, let me just say that the feedback around the training, the metrics and the surveys were unacceptable and frankly embarrassing. And we noted that in our initial testimony when we made this acquisition. We have since, at our expense, brought in third parties to look at the entire training process, to critique it, to give us feedback. And I think working together with VA and VHA, we will unveil a new training process. In this day, too, I still struggle with the idea, and this is my personal opinion, not being a doctor. I still struggle with the idea that we have to put people through extensive classroom training to learn to use a system. I mean, you don't have to learn to use many IT systems these days. It should be fairly intuitive to be able to pick up a system and use it. That said, there are specialty workflows, there are specialty things that do require some training, but I think you'll see us move to a just-in-time, more iterative model for training rather than an extended, elongated training. I mean, very few people inside an organization like this will use the entirety of the system. They have a role. They're radiologists, they work in the ICU, they do something that's specific to their job. And I think some of the mistakes, and these are our mistakes, this is our job to fix, was that the training was too cumbersome, it was too all-encompassing, and not enough of it was role-specific to say, this is your job and this is how you get the benefit to the system. To Dr. Nebiger's point, we've also rolled out existing telematic information into the system, telemetry into the system, so that we can actually see when people are struggling. We can see that there's an excessive number of clicks for certain workflows. People are spending too much time. It should only take you 30 seconds to do this, and you've been there for 3 minutes. What's going on? We should be able to get real and direct feedback and fix it at the time. I think waiting to the next time you come back to the classroom, it's just not the way that we should be rolling out training. And again, I'm owning this. I'm not pointing any fingers here. It's not the way that we should be rolling out training in 2023, let alone 2024, coming up with the go live resets.
And lastly, are you also just balancing, managing clinician buy-in, which, obviously you need to get, with their interest in optimization and specifications in for their specific needs? I mean, you can't move so far towards clinician buy-in that we're right back at a Vista, customization system.
Well, if I may give my observation as to one of the problems I think at the beginning was that there actually wasn't enough clinician buy-in in the beginning. Now, you're right. We have to be careful that we don't go too far, that we end up with custom systems. At some point, we have to snap a chalk line, because if we don't snap the chalk line, we're not be able to get to. But Dr. Nebiger mentioned the forum we had in Kansas City, where there were over 100 people attended from various VA sites, some live, some not. In fact, many not live, working together with the VHA, with the councils, and with Cerner. And I think what you saw was, a very good exchange of ideas, and we had clinical voices being heard, maybe they feel like for the first time. And I think that feedback is very important. It is also possible to roll out systems, and I used the word tweaks earlier. It is also possible to roll out systems with national standards, with national baselines, and allow, if there is something that is site-specific that may happen, because there are different sites that do different things. They have, that some of them, don't do all the advanced care. Some of them are more acute or more ambulatory. It's possible that we could tweak that without actually breaking that chalk line, without actually changing the national standards, by just giving label changes or something that's a little bit more intuitive, that don't change the underlying architecture of the system. I think those things are important. I think those voices are being rightly held. I do think that the change management process is underway right now is very different than it's been. And I think we're getting to a point of snapping that chalk line. I will say, as I said in my opening statement, that is, in my mind, the key to success.
Thank you. Yeah, yield back, Mr. Chairman.
Are there any organizations of doctors, nurses, unions, any of that are throwing up roadblocks in this process? Is everybody on board?
Yes. It's my
I don't want organizations organizing against our projects.
No, I mean, I think I don't see that as being a problem.
Because I know that I've been around government for a long time now, and people are very reluctant to change. They really are. Because it's too easy to do it the way they know how to do it. And the minute you start changing it, they don't want to change it. When you finish changing it, they love it, because now they can do it. And that's an issue that's personal to most people, actually. But I don't want anybody organizing that rebellion. If so, we're gonna have to figure out some way to have a conversation with them. Mike, when he was talking about what they're doing right now with the current previous group's work product that you're working with, you're still, all this stuff that they're doing right now on the previous group's work product, which is now part of your group, is not going to influence your. They're learning, if they're learning something off of the experience we had on the West Coast, that learning would carry over to the work product that's ultimately going to be part of yours.
That's correct. We're not changing the work product, we're enhancing the work product. So we've inherited all of those lessons, and we will roll all those lessons, and they are part of the 270 items that are being addressed right now. We will roll them into the new work product, which will be deployed in March at the North Chicago site.
I think one of the things that's peculiar to people that when you're dealing with the difference between government and private industry is private industry just says, we're going to do this, like it or not. And if you don't want to do it, then somebody else can be hired to do it. And I personally think that's a good idea. If you're going to stand up and say, I won't do it, here's your retirement papers. Have a nice day. And that's what happens in private industry. And ask them, if you don't know, ask Elon Musk. He fired half the people working for that outfit he just bought. And he gave them a retirement benefit too. So I just want to make sure that we're not running up against an organized effort, because we can't stand it's too long to run up against an organized effort. Now, here's one thing that's going on. I'm not going to go into detail about it, but there are some people that are advocating walking away from the current EHRM program to maintain the current VISTA system and start over. You want to comment on that? There are people that are advocating it in Congress right now.
So, I think what you've heard over the course of our discussion this morning is that the department is committed to moving forward as part of the federal EHR, in partnership with the Department of Defense, in partnership with the United States Coast Guard, in partnership with NOAA, partners in delivering the federal EHR, and that we see value in a single enterprise EHR that supports the entire system, that is fully interoperable with the Department of Defense, has connections with community providers to provide the data that clinicians need. That's the direction that the department is committed to going. There is value in doing this together.
Well, I sure hope so, because we've been in this for a long time. And when we started out, you had the best, and DOD did not have the best. They were the ones that were keeping those records where the kids had to stay over here sleeping in the hall until they got the records. And now they've done it, and we haven't stayed with them, and that's tragic.
Thank you, Mr. Chairman. I represent the state of Florida, and so we're probably looking at another decade before we get a rollout. That's kind of the word anyway. So one of the things that I have a question on, Mr. Cecilia, is when Cerner started into this, they realized very quickly that the problem was the hardware backbone couldn't support the software that they were trying to develop. And so then it became the realization that we had to change the entire VA IT backbone. Now, I'm asking for the state of Florida, since we have a very large veteran population, as you know. What can we tell those folks about, advancements that we're going to make within Florida? Are we going to be able to improve the backbone while we're waiting for the software? Or does it have to come at the same time? How are we going to maintain Vista during this next whatever period of time it takes for the rollout? Mr. Celia?
Well, with regards to the new system, the whole premise of moving systems to modern cloud-based systems is that you don't need the hardware in the local centers to be able to run it. What you do need is you need connectivity. You need laptops and things like that to be able to connectivity, but you don't need the what's called the server farms, which are the large sophisticated machines that run these. As far as maintaining Vista for some period of time, that would be probably more directed to the IT team at VA. What I can say is that you mentioned it's going to take a decade to roll out in Florida, and I sure hope that's not true, and I don't think it needs to be true.
I do too.
Because I just, in my personal opinion, running old systems is risky, and that system's only going to get older. The Vista system was rolled out during the Carter administration. The database that powers it was developed at Massachusetts General in 1965. Hasn't changed very much since. In this day and age, and cyber issues and things like that, I don't think that we want to maintain old technology any longer than we have to. And that's true in any industry. That's not specific to VA or specific to our banking customers are doing the same thing. That's why they've left mainframe and moved to modern systems. So I do think that this baseline and this chalk line and getting us to moving to a national system as quickly as possible is not just a benefit for veterans, not just to benefit providers, but it's also a risk mitigation strategy to eradicate very old technology, which is only going to continue to get older. If we have to wait a decade, then we've failed, because I don't think that would be an acceptable outcome for this at all. Again, nor do I think it has to be. I don't believe that we have to do that. That's my personal opinion. Obviously, VA has an opinion too.
So I think what I would tell your constituents is VA and Dr. Elnahal is committed to the standard of care that's consistent across the country. That just because we're deploying a system in Ohio or in Washington State or Oregon, that the standard of care is going to be the same. Well, how do we do that? Again, by there's a lot of shared, I definitely think we need to move to a commercial system. So let me just be super clear about that. But a lot of the capabilities are comparable for Oracle and VA for the care provision, for providing that decision support, for helping with orders, for collecting data from the patients on forms. And we're going to maintain parity. Again, there's some work to do here. It's not like it's an easy thing, but we're going to maintain parity. So we're collecting we're using the same form in Tampa as that we are in Spokane. And so the data we're collecting and then the orders that we're issuing and the care pathways we're following will be the same. In addition, there's more than just the EHR. There's other technologies. So for COVID management, when someone shows up in the emergency room, we have separate applications. There's new technology that works alongside of the EHR. So we're using this new technology at the Vista sites and at the Oracle sites. And we just deployed this at the Block 9 upgrade a few weeks ago. Similarly, for lung cancer screening, one of the most cost-effective interventions that we have in medicine right now is we're using applications in Vista and in the Oracle system. So it's not only the EHR. We're able to bring in this burgeoning market and new technologies to more powerfully address decision support and patient management that work in both systems.
Okay. And I think that goes back to the advances that you were talking about, correct?
That's right. The EHR, as I mentioned earlier, is, and as Dr. Neviker just highlighted, it's in essence the operating system of the hospital. But there are other applications that need to work orchestrated, integrated with those applications that are what are going to deliver value over time. There was a mention of artificial intelligence. There was a mention of other technologies. Those are telehealth technologies. Those are technologies that integrate and are, extensions of the electronic health record, and that we can deliver in partnership with both Vista as the operating system and the Oracle records, the operating system, to start to deliver standard experience.
That's what I wanted to know. Thank you. That's perfect.
I have one
I
more
yield back.
question. I had a fight with one of our, another friend of ours, one of our authorizers about a policy change that you made locally. At the Temple Hospital, there were a lot of women who were complaining about having to go past all these men and getting all these whistles and hollers. And so they decided to make Waco women's specialty and leave PTSD at Temple. That wouldn't change with the new system. Now Waco supposedly is a women's health specialty area. Maybe it didn't turn out that way, but that's what I was told. I know we are having very good success with PTSD and brain injury, both at BAMSI and locally, at least as good a success as you can get. So I just wondered, would changing the system change a hospital that's been designated as a woman's specialty hospital?
No, it should not. It will not. In part, this is where, we're designing the system so that it can support women's health care, management of PTSD, primary care, rheumatology, name the clinical specialty. If a medical center is delivering services that are unique, that module, those workflows would be turned on to support that medical center. And so when we're talking about standardizing a baseline, it doesn't mean that we have to deliver the exact same services at every facility across the enterprise. What it means is that when we're delivering women's health care, that we're able to deliver that where it's available, which should be everywhere. We're able to deliver that in a consistent way across the enterprise.
Okay, that just personal fight. Thank you. I think we're all through. Thank you very much. We'll see you very soon, probably.
All right. Thanks.
We're adjourned.